So the vaccine rollout has been a real adventure. You know, it's really being controlled pretty much centrally from the state health department in terms of how the allocation is done, who gets vaccine, and what vaccinating entities get vaccine, how much they get, what type they get, that sort of thing. So that's, in fact, we're going to have a news conference this afternoon just to sort of try to explain some of that to the public, because I'm pretty sure that for people looking from the outside in, it's very hard to understand what's really going on. And if somebody signed up for a vaccine, is waiting for a vaccine, they're really sort of in the dark. I sort of feel that. Initially it went out to hospitals. The strategy there, was trying to get the frontline healthcare workers vaccinated. The hospitals were given a mandate to they could vaccinate up to 50% of their own staff, and then they had to help other hospitals, EMS, and outpatient healthcare providers. That, I think, went pretty well. We used our healthcare coalition here in Jefferson County to sort of help direct traffic. If there was a hospital that had extra vaccine, then we would help, get it to another area, or vice versa if they didn't have enough. Our health department got some vaccine as well, just 500 doses of Moderna. That wasn't a whole lot, but, we had to do the same thing. We could vaccinate a few of our own, and then we actually helped vaccinate Children's Hospital staff and Grandview Hospital staff. And then we had we stood up some, like a Saturday clinic to get some of the outpatient people and that sort of thing. So I think the rollout for the healthcare providers in this 1A actually went pretty well. There was clearly some delay in getting vaccine out. Even our own health department, we got our delivery like the day before Christmas, and we weren't going to start vaccinating on Christmas holiday, and we still had some planning to do. So it was about a week before we actually started vaccinating, maybe even a little longer than that, because it is pretty complicated to roll this out. The logistics, the managing the vaccine stock, thinking about the first dose versus second dose, doing the social distancing while you do it, the 15-minute observation afterwards. So it takes a lot of work. Moving on from that to the 75 and older, I think when we got to the 75 and older and the first responders in Jefferson County, we had already started on the first responders some, and we were pretty much ready to start on the 75 and older as a county, partly because there were significant numbers of healthcare workers who chose not to be vaccinated. That was kind of an interesting sort of phenomenon. And that's gone fairly well, I think. I think it's gotten a little bit out of, it's what people don't know maybe, or some people don't know, is our health department's not really in control of what all is happening. It's all coming from the state. And, they've continued to give vaccine to some of the hospitals, and they're starting to make it available to a few other places. I think we have 3 pharmacies now that have it. And they're starting to get it out to some other outpatient clinics, but it's really been slow just getting vaccine. And for our health department, we pushed hard and started vaccinating, and we said we could do 3,000 a week. And we started doing it here at our main health department site in our parking deck, a pretty good operation where we could do about 400 a day. And then, some extra where we were planning to go to different areas of the community and start vaccinating, like a 1-day pop-up. And then we just couldn't get vaccine. And we said to the state, and others said, can we know what we're going to get so we can plan? We would like 3,000, we can do 3,000 a week, starting in February. And they told us, we'll give you 800 a week. And that's all you're going to get for the month of February. And And then we looked at that and we said, wait a minute, that's not even enough to do our second doses for those that we did in January. And this was a problem across the state where everybody had to call the state and sort of get that straightened out. And they did give us some extra, but basically for us as a health department, we were geared up. We hired extra people. We got, logistics all worked out. And yet we're not getting enough vaccine. There are some of our federally qualified health centers. We have 4 here in Jefferson County. One of them got some vaccine about 2 weeks ago. Another one got some last week. There are 2 that are still waiting. It's right now, we have plenty of capacity to vaccinate. We can push out vaccine as a community, but there simply is not the supply. So at least we don't have that problem of saying, well, we don't have enough capacity to vaccinate. UAB has been, the biggest vaccinator, and they've done a great job. They're part of this one of these mega sites. The state said they wanted to do 8 mega sites. And so UAB is one of them. We advocated for that, saying they've got the firepower, they can do it. They chose to do the Hoover Met partly because it's a ideal type of location. What a lot of people don't understand is that that's to help serve a larger region. They're given extra vaccine for that does not pull from our allocation in Jefferson County. It's extra. So they're serving more than Jefferson County. They also agreed to do something in the Smithfield community, low-income community at Parker High School, a little smaller scale. That's been a little slow to get up and going. And so I guess that gets over into the topic of the issue of equity. And I'm really, really worried about that. I'm very concerned about that. I'm a little emotional about it. I'm sorry, because we've been fighting and just trying to help advocate for some of these clinics and things that are in lower income communities to say we're starting to see a problem already. And we've got to get it to our low income and mostly Black and brown communities. And it's just not quite happening. And even in our own clinic, when we set up this call center, we set up a call center really quickly in order for people to be able to sign up, because everybody's phone was ringing off the hook when it was known that there was vaccine at UAB, there was vaccine at the health department, et cetera, et cetera. It was just a mess. Everybody was calling everywhere. So we quickly set up a call center to try to channel the phone calls and at least get people on a list, and then start, saying, okay, can you do this many? We'll sort of divvy these up. That list right now has about 140,000 people on it. And we don't have any vaccine, but UAB did agree to take some of the people on that list. We did a fair number in January, but the people that were on that list, it was probably about 88% white. And, it's just who happens to sign up first and get in line first. And, there's some issues with internet access, things like that too, although we called people that did not have email addresses. But we are seeing, from the get-go, we started seeing racial disparities emerge. And it's not just, some of it's vaccine hesitancy, but it's not just vaccine hesitancy. It's all sorts of things. And, we have to figure out how to correct for that. And so that's what we're having conversations about. I'm talking to UAB about it constantly in terms of their rollout. And we're just trying to say to the state, help us make sure we know our community, we know where the needs are, we know who can vaccinate. Let us help guide you so that we can try to get it to the right places. We're also doing a lot, we're trying to do a fair amount of education for the African-American community and for the Hispanic community, using African-American doctors and Spanish-speaking doctors to present information on vaccines, mostly starting with community leaders. We did some for the Birmingham's 99 neighborhood officers. We did some with some African-American pastors. We have a separate effort reaching out to Spanish-speaking community leaders. And we're just getting started with that, but we've done several sessions and we will do some more, but mostly working with influencers right now. So that's sort of an effort. We're doing a big media buy, which will, more and more try to help overcome vaccine hesitancy and target these communities. The state is doing the same thing.
What we're seeing these days are that generally across all districts that that ADPH has, we're seeing the trends that it ticks down. There was a slight increase in Tuscaloosa following we think, what happened with the national championship, because it did coincide about 4 days after that. Tuscaloosa is represented by the West Central District here in red, and they did start to tick up a little bit, but they're coming right back down. And we've talked to Ricky Friend over in student health, and they're back under control. It was really only about a week, which is good. That's what we would hope, that it didn't go as long. So that's one positive indicator that we're starting to see all counties trend down. And as I've talked about before, but this particular outbreak really started up in the north central part of the United States, and it bled down and then out east to west. It's the first time we've seen the epidemic march across the country like that. Which is unique epidemiologically in the characteristics. It probably means there was a rapidly spreading variant that moved through the country in that way. If you watched it, it literally, like dominoes, tumbled from one county to the next across each state line. Same thing happened in Alabama. Started in the north and it went right down to Mobile. And you can see some of the southern districts were the slowest to recover, but again, they were the last to be hit. So again, if the national trend for what we're seeing holds, we should be back below 25 cases per 100,000 by mid to late February. There's plenty of evidence from that, again, in that mid-central region of the US. They're really starting to recover, even though some of those states do not actively practice COVID mitigation strategies. They're still recovering. So again, we've got indicators pointing in the right direction for us. You're seeing a lot about weekly deaths in the news, and it's really important to note that deaths don't always get processed over holidays. So it's, I was on a call the other day and somebody was talking about how we have more deaths than anybody else in Alabama. But if you actually look at it, and this is from Bama Tracker, where by date of death, it is starting to come down. That the deaths are starting to come down if you look at the day the person died and not the day the health department was able to get the information. So, again, that's an indication that we're going in the right direction. So it's the deaths are pointing in the right direction. The cases are pointing in the right direction. Probably most exciting are that the hospitalizations are really going in the right direction. The estimates for this month are that they're going to continue to track down. This little dashed line, we would have anticipated that hospitalizations would have bumped back up again following a slight rise in January, but they didn't. And that likely could be due to the more widespread use of the monoclonal antibody therapy. Mike Sag has been talking about that a lot lately, and he estimates, the last I saw, it was in the hundreds of hospitalizations that were prevented in Jefferson County. So that is exciting that perhaps we've got therapies coming in addition to the vaccine that's helping to keep hospitalizations lower. Age-wise, by age group, we're, and you've seen this chart before, the gray line, those are the college-age students. Actually, on the recommendation of this group, I changed it to make the age intervals consistent. So they're basically 10-year age groups, except 0 to 17 and 68 plus. And you can see the curves all kind of line up more on top of each other when you do that in the 10-year age groups. But here are the college students. This is the big peak that we saw in August and September when the universities started back up again. The most interesting thing, as we talked about before in this peak, is that didn't seem to bleed down into other age groups like it did in other states. Other states saw a peak that hit in other age groups, but we did not in Alabama. The line that's pretty consistently across the bottom is the 0 to 17-year-olds. And you see when they left school, right around the end of December, their cases started to go down. But now that they're back in school, their line is lining up pretty much with everybody else's line, which is where it has been for most of the time that they were in school. So again, epidemiologically, it's behaving like it's behaved in the past. So there's no reason to think that the trend that we're seeing won't continue.
The NIH put out a call for volunteers and got something like 700,000 people who were willing to give blood samples to assess the seroprevalence in the US population. Of those, we reached out to something on the order of 15,000 people using a stratified sampling strategy that was supposed to give us both nationally as well as demographically representative feedback on what the actual seroprevalence was. To that end, we wound up with about 12,000 returned kits. I must confess, I'm a little disappointed in this paper, and another, not just that I'm the 42nd author, but it's really the NIH showing the tour de force of their clinical lab capability rather than actually talking about the outcome of the study. So hopefully we will get to that in another study. With that said, the short answer is for every case detected, there are about 4.8 undetected cases, meaning that there's a 5.8% prevalence rate out there at the time of this. This was round one. We are currently in the midst of doing the 6-month follow-up with the same population. And that ought to go to, when we get those studies back, give us some information that may rebut the Columbia study about what the actual rates are. We'll be able to make a better estimate. The other part about this is we learned, and I scroll down to the table, that, and this goes directly to Suzanne's point earlier, that we, when we look at the age groups, that the younger age group is actually more prevalent. And if you were to take that information in light of previous studies, for example, there was a fairly famous Japanese study circa 2001, where they decided to vaccinate against influenza in school-age children rather than stratifying by age and going from oldest to youngest. And when they did that in Japan, they decreased their mortality by like 3-fold. And so with our study, some of what Suzanne was telling you about transmission, if the goal were to break the transmission rate of COVID, we might have a wildly different vaccination strategy, is what I'm going to tell you, than we're currently pursuing.
So this table shows the makeup of the study population. Can you show a table that shows the results by age group?
I can tell you that the prevalence is higher in the lower age groups. Essentially, and we had these, and they wouldn't use them. I don't know why. We had nice line charts with age on one axis and prevalence on the other, and it's much more prevalent in younger populations, as you would expect.
As you can see from this chart, we are in our 8th month of case investigation, contact tracing for all counties in Alabama that are not Jefferson and Mobile. You can see that we ramped up rapidly to a peak in October, then it began to slide off a little bit in November and December as the term ended and we began to lose students, and now we're building back up the workforce. These are the billable cases per day. The difference between the two is between the cases we touch and the cases we can actually bill has to do with the ability to complete the case and collect all of the necessary information and get it in the data recording system. So there's a little bit of a difference between those. But we're in January, we're back up above where we were in December, not where we were, where we would like to be, but we'll be there very soon as the last cohort of investigators will complete their training in the middle of next week. We are mailing a number of letters. They're down a little bit in December and January. Again, that's a reflection of the number of investigators we have. The investigators, as they go through, they generate and they make calls, and the protocol is to make 3 attempts to a patient under investigation, and if that patient is unreachable, then we send a letter and ask them to please contact the case investigator, and we follow up. We're able to receive something on the order of 17% of the letters we send produce callbacks. It doesn't sound like a very high number, but it's from what we understand from the Alabama Department of Public Health, we're some 6 or 7 percentage points higher than the other vendor that's working in this area. What I have not shown so far, and will here, is the organization of the group. We have, as you can see, a number of teams. We have, if you count them, if you add all those up, you'll see that there are 15 teams of case investigators. Each team has a lead, and each lead has somewhere between 6 and 8 investigators working for them when we're at full staff, and we're just about at full staff at the moment. So we're making progress, and great to have this opportunity.
I did want to take a minute. You should be seeing the UA system COVID-19 dashboard. I encourage you to take a look at this. It's been revamped. I think they've done a nice job with this. You can see the weekly data for UA, for UAB and UAH, students, faculty, and staff. You can see the current occupancy of isolation space for the different campuses. And then the sentinel testing and what that has looked like. You can see it in graphical or tabular formats. Again, I think they've done a nice job with the site. It's a good way of just keeping your fingers on the pulse of what's going on in our campuses. Again, if you expand these, you can see how things have changed in the 2 or 3 weeks we've been back on campus this semester.